This recorded lecture will be going over Chapter 38, the Reproductive System. The female reproductive system depends on hormones produced by the endocrine system for the correct development and reproductive function. Puberty and sexual maturation are also dependent on accurate release of hormones at the appropriate time in the cycle. Reproductive health can be disrupted by a variety of disorders, like infertility, spontaneous abortion, premature labor, infection, and the growth of abnormal tissue, including cancerous and non-cancerous tumors. The reproductive organs represent the biological aspect of sexual identity, and women may feel that their personal identity is compromised by disorders of this system. The vulva is the external female genitalia. The mons pubis is a rounded mound of fatty tissue that protects the symphysis pubis. It is covered with pubic hair. The labia majora are two elongated, raised folds of pigmented skin that enclose the vulvar cleft. The labia minora are soft folds of skin within the labia majora. The clitoris is located at the top of the vulvar cleft, above the urethral opening. The urethral meatus, or external opening of the urethra of the urinary bladder, is located below the clitoris within the folds of the labia minora. The vaginal vestibule is situated below the urethral meatus within the labia minora and is the entrance to the vagina. The perineum is the flat muscular surface between the vagina and the anus. The vagina is a muscular tube lined with membranous tissue and that has transverse ridges called rugae. The uterus is a hollow pear-shaped organ with a thick muscular wall. The lower opening of the uterus is the cervix, which dilates during labor to allow for delivery of the infant. There are two fallopian tubes that branch outward from the right and left sides at the top of the uterus. They will form a pathway for the ovum or egg from the ovary to the uterus. There are two ovaries, one located near the end of each fallopian tube. At birth, the ovaries contain all of the eggs, or oocytes, that the woman will ever produce, approximately 2 million in each ovary, most of which will never mature for possible fertilization. The bony pelvis, located at the base of the body between the hips, supports the pelvic organs, including the growing uterus during pregnancy. It is assisted by the pelvic floor, a collection of strong muscles and supportive tissues that brace the pelvis and provide both support and protection for the pelvic organs. The breasts or mammary glands are located on the upper chest, and these are accessory organs. They are composed of fibrous, adipose, and glandular tissue and are responsible for lactation, which provides nourishment for the infant. The ovarian cycle has two phases. The follicular phase, this is the first 14 days of a 28-day cycle. Follicle stimulating hormone, or FSH, and luteinizing hormone, or LH, will stimulate the maturation of the ova in preparation for fertilization. Estrogen will peak when the ovum is released. This is known as ovulation and occurs about 14 days before the next menstrual period. The luteal phase occurs at day 15 to 28 of the 28-day cycle. LH and progesterone are the primary hormones released during this phase. If fertilization and implantation do not occur, the lining of the uterus will degrade and be shed during menstruation, and the cycle begins again. The menstrual cycle has 4 phases. You can read about these phases on page 908 within box 38.1. During the first weeks of pregnancy, the male and female sexual organs are undifferentiated. After the 7th week, rapid changes occur, and by the 12th week, the external genitalia are formed and fully differentiated as male or female. Puberty is the period of sexual maturation. It usually occurs between the ages of 9 and 17 years for girls, with the average onset being 12 years of age. Puberty is accompanied by the onset of the menstrual cycle, also known as menses. The beginning of menstruation is called menarche. Menstruation, which is the shedding of the uterine lining, will continue at intervals of approximately 4 weeks throughout the childbearing years, except when pregnancy occurs. Toward the end of the childbearing years, women will become perimenopausal, entering the phase known as the climacteric period. The menses will become irregular in both pattern and flow and eventually will stop altogether. Menopause has occurred when the menses have completely ceased for at least 12 months. Signs and symptoms of the climacteric period and menopause include hot flashes, hot flushes, and night sweats caused by vasomotor instability resulting from low estrogen levels. Healthcare education for adolescents should include information about puberty, menstruation, and sexuality. Teenagers and young women will need information about safer sex, contraceptives, and choices concerning high-risk behaviors. Adult women will require information about pap smears, breast self-examination, nutrition, exercise, and lifestyle management. Older women require information about menopause, long-term illness, and disabilities that affect their healthcare needs. During the first year after menarche, the menstrual cycle could be somewhat irregular, but by the second year, a regular cycle of approximately 28 days is normally established. Incorrect perceptions about this normal process could increase physical discomfort or cause a young woman unnecessary embarrassment or fear. A healthy view of menarche as a natural physiologic process marking the reproductive maturity should be encouraged. Menstrual bleeding occurs about 14 days after ovulation and lasts between 2 and 8 days. Menstrual blood consists of endometrial tissue, blood, mucus, and vaginal and cervical cells. Once a menstrual pattern is established, a change from this pattern is reason to consult your healthcare provider. The length of the cycle can be influenced by stress, drugs, nutrition, and illness. Women should be encouraged to keep a calendar of their individual menstrual cycle to determine regularity and recognize deviations. Mittelschmerz is a sharp pain in the right or left lower quadrant, sometimes felt at mid-cycle around the time of ovulation, and this could last a few hours. Normal vaginal secretions contain cervical mucus, endometrial fluid, exudate from the Bartholin glands and Skene ducts, and products of normal flora. The main line of defense against infection is lactic acid, which causes an acidic pH. Normal vaginal discharge has an off-white color and is odorless. If the vaginal discharge develops an odor, changes in color or consistency, or causes irritation or burning of the vaginal mucosa, a healthcare provider should be consulted. Breasts are made of adipose tissue, milk-producing glands called lobules, ducts, and fibrous tissue that rest on the chest muscle. They may not be completely symmetrical. One could be larger than the other, and they may feel a bit lumpy and tender, especially during the middle of your menstrual cycle. Age, pregnancy, medication, and diet can all affect the way your breasts feel. Information about techniques of contraception is essential to prevent unwanted, unintended pregnancies. Women should make an informed decision concerning methods of reliable birth control, and you are responsible for providing comprehensive education concerning the advantages, limitations, and side effects of various contraceptive drugs and devices available. The most effective contraceptive methods for adolescents and young adults include abstinence, the use of planned contraception, the correct use of condoms to prevent STIs, and lifestyle counseling. Natural family planning, also known as fertility awareness, involves identifying signs of ovulation and abstaining from intercourse during periods of fertility. The basal body temperature technique involves monitoring the BBT each morning and noting a rise that occurs at ovulation. The calendar or rhythm method is based on the knowledge that ovulation occurs 14 days before menstruation, and therefore keeping track of the woman's menstrual cycle can help predict the time of ovulation. The Marquette model of natural family planning incorporates the use of an electronic hormonal fertility monitor that tracks the levels of urinary metabolites of estrogen and LH. Natural family planning requires the commitment of both partners and close, accurate monitoring during the menstrual cycle. Oral contraceptives are the most popular method of reversible hormonal contraception in You should counsel women on options and collect data that can determine which OC is best, if this is the method of birth control the woman prefers. Traditional OC regimens are based on a 28-day cycle with a 7-day hormone-free interval that allows for menstruation and gonadotropin levels to rise and ovarian follicular growth to occur. Other OCs can reduce the hormone-free interval, therefore reducing menstrual discomforts as well as decreasing the risk of contraceptive failure. Smoking increases the risk of complications related to OC therapy, especially in women over the age of 35. On page 911 through 914, within Table 38.1, you can read about the different methods of contraception. Known as the morning after pill, emergency contraception may be considered after the woman has had unprotected intercourse. This is not meant to be used on a regular basis. Plan B one step, a tablet of levonorgestrel, is available over the counter in the United States and is to be taken within 72 hours of unprotected sex. The woman should be referred for counseling and follow-up care after the use of any emergency contraception. A copper intrauterine device, or IUD, can be inserted up to 5 to 7 days after unprotected sexual intercourse to prevent implantation of the zygote in women who prefer a long-term contraception method. Hormonal changes and the cessation of menstruation will signal the onset of menopause. Family support is helpful to maintain a sense of purpose in life. Western culture values youth and beauty, and the onset of menopause may be seen by women as a loss of attractiveness or the first step towards old age. You must understand the perceptions of the woman and the family before designing and implementing a teaching plan that is patient-centered. Primary prevention is designed to decrease the probability of becoming ill, such as by maintaining a health or nutrition history and providing immunizations. Secondary prevention involves screening for detection of specific diseases a patient is at risk for, so that early treatment can be given. Tertiary prevention minimizes the impact of an already diagnosed condition. Health screening will begin with the woman's visit to her healthcare provider. The data collected will identify the patient and summarize their personal health history, the community in which she lives, and her available support system. All data collection should include information regarding the use of non-prescription as well as prescription medications and complementary and alternative medicine or CAM therapy. Breast self-examination, or BSE, is optional, and it may be done monthly, about 1 week after menstruation begins, or on a specific date each month after menopause. Mammography and MRI for women at a high risk of breast cancer are other forms of screening tests. Testing for the BRCA1 and BRCA2 gene mutations can be offered to patients with a high familial risk of breast cancer. Many women are unaware of the importance of vulvar self-examination. VSE should be performed monthly. This is usually done in a sitting position. One hand can be used to hold a mirror, and the other separates the labia and exposes the area surrounding the vagina. Using both touch and visualization, the self-examination begins at the top of the mons pubis and works downward to the clitoris, the labia majora, the labia minora, the perineum, and finally the area around the anus. Any changes should be reported to the healthcare provider. These would include any new moles, warts, or growths, new areas of pigmentation, especially white, red, or dark skin areas, ulcers or sores, and any areas of continuing pain, inflammation, or itching. Treatment of malignancies that have been detected early can prevent surgeries like vulvectomy and prevent metastasis. Providing the woman with a clear explanation of what will be done and what she can do to minimize discomfort during any diagnostic test is essential. All patient questions should be answered clearly and accurately before the procedure begins. Assemble the equipment and direct the woman to take deep breaths and relax all muscles during exhalation. On page 916 through 918, within Table 38.2, you can read about common gynecologic diagnostic tests and diagnostic procedures. During a pelvic exam, the speculum will be gently placed into the vagina by the healthcare provider. Specimens can be collected for laboratory examination. A pap smear may be obtained to determine the presence of abnormal cells. After the examination, assist the woman to a sitting and then standing position. Disposable tissues can be provided to wipe lubricant from the perineum. Teaching can include a review of purpose of the test performed and should include education about the need for routine checkups, pap smear, and HPV testing. The American Cancer Society guidelines include screening for cervical cancer every 3 years via a pap smear in women between the age of 21 and 65 years. After age 30, it is recommended to include an HPV test with the pap screening. Collect essential data regarding the patient's reproductive history and any gynecologic concerns. Collecting data about sexual health and sexual practices is an important part of routine data collection. Sexual health information should include the 5 Ps: partners, practices, protection from STIs, past history of STIs, and prevention of pregnancy. Ask questions in a tactful and objective manner and appreciate that the patient has the right to choose not to answer. Do not assume sexual preference or gender identity. The male gonads are the testes. They are oval-shaped and are encased in the scrotum along with the epididymis, seminal vesicles, and vas deferens. The scrotum is covered with wrinkled skin known as rugae and is very sensitive to temperature, pressure, touch, and pain. The penis is a cylindrical erectile organ that hangs in front of the scrotum. The penis is covered with skin and includes a foreskin unless circumcision has been performed. The scrotum and penis make up the external genitalia of the male. The prostate gland is shaped like a walnut, encircles the urethra, and is located below and to the rear of the bladder. The scrotum, a thin-walled muscular sac, holds the testes, the epididymis, and the vas deferens. The scrotum hangs from the pubic bone and suspends the testes outside of the body, where they remain several degrees cooler than the body. This cooler temperature is needed to produce viable sperm. The seminiferous tubules within the testes produce sperm. This is known as spermatogenesis. Testosterone is also produced in the testes. The epididymis is a long tube, almost 6 meters if uncoiled, that conducts sperm from the testes to the vas deferens. The vas deferens is a muscular tube that connects to the epididymis. It stores sperm and then carries it to the ejaculatory duct by peristaltic movements. The seminal vesicles produce a fluid that is thick and contains fructose to nourish the sperm and provide energy. The fluid also contains prostaglandins, which contribute to the motility of the sperm. This fluid mixes with the sperm to form seminal fluid, or semen. The average volume of semen ejaculated is 2.5 to 4 mLs, but it can vary from 1 to 10 mLs. The prostate gland produces thin, milky, alkaline secretions that contribute to the seminal fluid and enhance the motility of the sperm. Thoughts, emotions, some medications, or medical disorders could sometimes inhibit an erection. An erection is when sexual arousal causes the penis arterioles to the erectile tissue to dilate and the veins to constrict, engorging the penis with blood until it is enlarged and rigid. If stimulation occurs and continues, ejaculation will occur. The penis transfers semen to the vagina. It also carries urine through the urethra to be excreted. The hypothalamus, the anterior pituitary, and the testes secrete hormones that control male reproduction. LH stimulates the testes to produce testosterone. Testosterone and FSH stimulate the formation of sperm. The male sex hormones are called androgens. Sperm takes 70 days to mature and are constantly being produced once puberty has occurred. Prostate enlargement may occur with risk of urethral obstruction. There is decreased sperm production, but fertility remains intact. Sexual activity in the older men is closely related to their sexual activity in earlier years. Vascular problems are the major causes of impotence. Certain medical disorders or the use of various medications may have side effects that can affect sexual function. The male reproductive organs are shared with the urinary tract, and disorders in functioning of one system will typically affect the other. If the anatomy and physiology of the male reproductive tract are intact, sexual function is influenced by the functioning of the hypothalamus, pituitary, and testes, the metabolism and transport of sex hormones, and the cognitive and sensory centers in the brain. A sexual desire or libido, the ability to respond to sexual stimulation with penile erection, and the ejaculation of semen containing live sperm are all necessary for fertility. Contraception is the responsibility of both the man and the woman. Reversible contraception involves the use of spermicidal creams, gels, or foams applied before intercourse to kill sperm in the vagina. These are more effective if used in conjunction with a condom. A male condom is an effective reversible contraceptive technique if applied and used properly. Proper application includes timing of application and removal and providing a space at the tip for the semen to collect. Oil-based lubricants such as petroleum jelly can cause latex to deteriorate, so these lubricants will reduce the reliability of latex condoms. It is important to suggest the use of water-soluble lubricants like jellies made for this purpose. Male sterilization by vasectomy is a popular method of permanent contraception. The term vasectomy refers to a surgical procedure performed on the vas deferens for the purpose of interrupting the continuity of this duct, which conveys the sperm at the time of ejaculation. Occasionally, a vasectomy can be successfully reversed by reversing the vasovasotomy or microsurgery if a man's life circumstances change. A vasectomy is done on an outpatient basis in a clinic or healthcare provider's office with a local anesthetic. The patient should be instructed to use ice application and acetaminophen or ibuprofen for scrotal pain and swelling within the first 12 to 24 hours postoperatively. The patient should wear jockey shorts or a scrotal support for comfort. Be sure to emphasize to the patient that 2 negative sperm counts are needed after a vasectomy before the patient can be considered infertile, and that some form of contraception should be used until that time. Because seminal fluid is manufactured in seminal vesicles and the prostate gland, there is no decrease in semen ejaculation after a vasectomy. However, the semen does not contain sperm. Vasectomy has no effect on libido or sexual performance and provides no protection from STIs. Because some male reproductive disorders are more common in certain age groups, the age of the patient is relevant to the nursing assessment. In men older than 50 years, the assessment will be directed more towards detecting prostate problems, whereas younger men are carefully assessed for STIs and testicular cancer. Because questions about urinary problems are usually less sensitive than those dealing with sexual dysfunction, it is best to begin with questions of this kind and then lead into the more sensitive ones. It can also be helpful to ask him to relate his problem to the impact it causes in his daily life. On page 922, see the green health promotion box. Regular self-evaluation of the testes, known as a testicular self-exam, for early detection of cancer is encouraged. You can encourage the patient to perform TSE and teach proper techniques and follow-up care. Tests for general state of health, like a complete blood cell count, urinalysis, chemistry profile, and thyroid tests, are often done initially when a patient has a problem concerning the male reproductive tract. On page 923, within table 38.3, you can read about some diagnostic tests for the male reproductive system. Blood and urine tests are performed to detect a UTI. Tumor protein marker studies are performed for patients with testicular cancer for follow-up to determine success of treatment or recurrence of the disease. A prostate-specific antigen or PSA test will detect the levels of glycoprotein produced by the prostate that can be elevated in prostate cancer. The term sexual minoritized is used to describe the LGBTQIA population. Research shows that individuals who identify as LGBTQIA avoid care, particularly because of previous negative experiences within the healthcare system. Disparities within this community will include the following: less access to insurance and healthcare services, including preventative care, lower overall health status, higher rates of smoking, alcohol, and substance abuse, higher risk of mental health illness like anxiety and depression, higher rates of STIs, including HIV infection, and increased incidence of some cancers. Care of patients who have undergone or are contemplating gender confirmation surgery should be approached from three important perspectives: the gender that the patient identifies with, the type of surgery that has been performed or to be performed, and/or genital surgery. Chest surgery is called top surgery, and genital surgery is called bottom surgery, as well as the natal sex. This is the sex assigned at birth. You should ask the patient which name and pronouns they prefer, and then use these as stated by the patient. Following surgery, hormonal therapy will be prescribed or continued by the healthcare provider. Remember to objectively teach patients about any health concerns that may remain based on their natal sex. The most important support and interventions that you can provide to all patients include compassionate care, acceptance, and knowledge. Specific examples of nurse advocacy include the following: ensure that the facility or agency is welcoming and safe for all patients. Advocate for unisex or single stall restrooms. Avoid making assumptions about sexual orientation and gender identity. Be aware of misconceptions, bias, and other communication barriers to care. Recognize that self-identity and behaviors do not always align. Honor and respect whatever information the patient shares with you about their sexual orientation and gender identity. Use neutral and inclusive language when talking with all patients. Familiarize yourself with credible online and local resources for LGBTQIA patients, and provide personalized care to all patients.